Hello, I'm Vamshi Rao. I'm a pediatric neurologist at NN Robert H. Lurie Children's Hospital of Chicago. I am joined by Dr. Noritz. Dr. Noritz, please go ahead, introduce yourself.
Yeah, hi, I'm Gary Noritz. I'm an internist and pediatrician, and I work at Nationwide Children's Hospital and The Ohio State University. And I work in a clinic that takes care of kids and adults with disabilities.
Thank you, Dr. Noritz. So, as a person, as a physician who's taking care of individuals with disability and DMD in particular, what are the logistical sort of needs for assessing and diagnosing these individuals with Duchenne muscular dystrophy?
There really are a lot of barriers that I think we can get through if we think about them. And it really starts in the primary care office, where we are hoping that the children are being screened using a standardized instrument. And the American Academy of Pediatrics recommends that we use these instruments at 9, 18, and 30 months of age. But the primary care office is a very busy place with lots and lots of patients and not a lot of time to see them. And so it's really important to be doing this kind of thing consistently every time you see a child at that age. And anytime there's any concern, either on the parent's part or by the primary care doctor, that there might be something different about the child's developmental trajectory. And so we really do recommend that those screenings happen at regular intervals. The other thing that we sometimes have seen be a problem is that if once there's a recognition that there is potentially a problem, that people wait to do some of the things sequentially rather than doing them all at once. And really, we can do all of these things at once. And so the recommendation is that we send a blood test looking for a muscular dystrophy such as Duchenne, the CK blood test, and at the same time, making a referral to a diagnostician that can make the diagnosis, a neurologist or physiatrist or geneticist or developmental pediatrician, and also simultaneously getting them started in therapy by referring to early intervention. So you don't have to wait for a diagnosis to get started with those things. Once we do get them to the specialist, what are the things you can do on your end, Dr. Rao, to make things easier for the family?
Yeah, thank you, Dr. Noritz. I think that's an excellent point in terms of the whole trying to do things in parallel than sequential. And I at my end really appreciate that sort of workflow that has already begun before the children are referred to me. I think at my end, depending on where the child is in their stage of diagnosis, I think a lot of education and support is needed for the family unit. And some of these education and support materials are definitely out there. They have been put together by family foundations such as the Parent Project Muscular Dystrophy, and there is a lot of information available at the Muscular Dystrophy Association website too. But I think what really also helps is making sure that these families and individuals have support groups around them. And they are aware of all that is going on in the field of standards of care for muscular dystrophy, research, and advocacy. And I think helping them access some of these or facilitating access from my end really goes a long way as I receive these kids and these individuals from you. But I think another important thing, or another important stage, I should say, that really goes full circle from me back to the primary care physician is this sort of transition of care that happens from children who then grow up to be adults. As much as I hate, sending my kids away, they do grow up to be adults. So, how do you see that as a primary care physician who's now handed an individual who's older and has Duchenne muscular dystrophy?
Yeah, it's such an interesting and great problem to have that boys with Duchenne are growing up to be men with Duchenne and functioning often very well. But the medical problems continue, and we need to think of transition in a number of ways. And one of them is the process of growing up and becoming an adult. And so that includes things like what are you going to do after high school, and where are you going to live, and how are you going to have insurance, and are you going to get married and do things like that. We also need to talk about the transfer of care, which has to do with moving on from a pediatrician to an internist, or a child neurologist to an adult neurologist, or a pediatric pulmonologist to an adult pulmonologist. And we really rely on our centers to help us with the specialists. But on the primary care end of things, we also need to help the family find a general practitioner, internist, or family medicine practitioner who can help to guide the family through the primary care part of things. The good news is that family medicine docs and internists are very well trained in taking care of complex adults. And so they may not have a lot of experience with the specifics of Duchenne muscular dystrophy, but most people will have a lot of experience taking care of people with heart problems and pulmonary problems and ambulation problems, and be able to provide that kind of wraparound care that they really need. But making those connections is often both difficult and quite heart-wrenching, both for the doctors and for the family. Am I right?
Absolutely. It certainly is a partnership.